Ultrafiltration, an Alternate Treatment for CHF by Tara Parek and David Clark. Learning objectives. At the end of this presentation, learners will be able to define congestive heart failure, risk factors and common symptoms, list current treatment modalities, describe diuretic therapy and its limitations, define ultrafiltration, list the pros and cons of ultrafiltration, and describe nursing implications for CHF treatment.
What is heart failure? The Heart Failure Society of America defines heart failure as a syndrome caused by cardiac dysfunction, generally resulting from myocardial muscle dysfunction or loss, and characterized by either left ventricular dilation or hypertrophy or both. The American Heart Association offers a less technical definition. Heart failure is when the heart can't keep up with its workload. If the heart muscle cannot pump enough blood, it cannot meet the body's needs for blood and oxygen. The diagram shows several common symptoms of heart failure, including tiredness or fatigue, shortness of breath, and edema. Risk factors for CHF include hypertension, myocardial infarction, damage to the heart valves or history of a heart murmur, enlargement of the heart, a family history of an enlarged heart, diabetes, or persons ages 65 or older. The New York Heart Association classifies heart failure into 4 classes, from mild to severe. In Class 1, there's no limitation of physical activity. In Class 4, the patient is unable to carry out any physical activity without discomfort.
Current treatments for CHF include some holistic approaches, like sticking to a low sodium diet and fluid restriction, as well as some common medications. Certain classifications are used, like beta blockers, which slow the heart rate to allow for ample filling time, and ACE inhibitors that reduce the overall fluid in the body, causing less pressure on the weakened heart. Although each is important, diuretics treat volume overload, which is the cause of most heart failure symptoms and accounts for 90% of hospital admissions. Diuretic therapy, considered the hallmark treatment of hypervolemia or volume overload. Nearly 90% of patients with acute decompensated CHF receive IV diuretics during their hospital stay. These IV diuretics rapidly alleviate symptoms of volume overload, such as pulmonary congestion, shortness of breath, and edema. The most common diuretics for CHF include the loop diuretics, such as Lasix, Demodex, and Bumex. These can be given either PO or IV.
There are limitations to IV diuretic therapy, including electrolyte imbalances, specifically with potassium and magnesium. When either of these are depleted, serious cardiac dysrhythmias can occur. Other limitations include possible hypotension, worsening renal function, and diuretic resistance, which occurs in as many as 30% of patients treated with IV diuretic therapy. So what happens when the hallmark treatment fails? And what is ultrafiltration? It is the removal of water and sodium from the blood through a filter and a mechanical device, seen in the lower left-hand corner. The blood is then returned to the veins via a closed pressure system. You can see on the right-hand corner how this is hooked up to that patient's arm. UF use with CHF and fluid removal has been cited in literature for more than 3 decades. However, the FDA recently approved the Aqueduct system by CHF Solutions and introduced the possibility that UF could be applied routinely in clinical treatment of CHF. The older method versus the newer method. The older ultrafiltration method was a slow, continuous method. It was similar to hemodialysis in practice. It required a central line and a critical care or hemodialysis setting. The newer FDA-approved Auqapheresis allows for faster treatments. Use of a peripheral or central line can be used and no longer needs to be done in a critical care setting, but can be done on the floor in a progressive care unit. Some facts about Auqapheresis are: it can remove up to 500 mLs or 1.1 pounds of fluid per hour. However, the average rate is about 250 mLs or half a pound per hour. And a typical treatment lasts about 24 hours, but is always geared to the patient's specific needs. Auqapheresis does require that patients are on a continuous heparin infusion to maintain anticoagulation. This requires lab draws every 4 hours.
UNLOAD was a prospective randomized trial that was published in 2007, the title of which is Ultrafiltration versus Intravenous Diuretics for Patients Hospitalized for Acute Decompensated Congestive Heart Failure. This study showed 100 patients that received IV diuretics for CHF treatment versus another 100 patients that received Auqapheresis treatments and no IV diuresis. The findings were that the UF group was less likely to need an unscheduled outpatient appointment or hospital readmission for CHF within 90 days, less than the IV diuretic group. The length of stay for the ultrafiltration group was 1.1 days less than the IV group. The cost of UF may therefore be offset by a reduced utilization of medical resources in follow-up. However, one recent study showed that even with rehospitalization factored in, UF was still more costly. The American College of Cardiology, the American Heart Association, and the Heart Failure Society of America have all long supported the treatment of heart failure and fluid overload by using ultrafiltration. The Aqueduct's FlexFlow has made ultrafiltration a more viable, accessible option for hospitals and heart failure patients alike. Some advantages of ultrafiltration therapy include a more rapid removal of fluid excess, which leads to a more rapid improvement in symptoms due to a greater removal of sodium and a more isotonic fluid removal. Other advantages are the decreased risk of electrolyte imbalances, the decreased risk of worsening renal function, as well as the shortened length of stay for heart failure hospitalizations and the decreased rate of heart failure readmissions.
So who would benefit from ultrafiltration? Well, the up to 30% of heart failure patients that develop diuretic resistance, renally impaired patients or those at risk for becoming renally impaired, patients who are frequently admitted or frequently readmitted. This would improve their quality of life because they would be in the hospital less. And of course, hospital staff would also benefit. At this point, we are no longer receiving reimbursements for patients who are readmitted under the same diagnosis within 30 days. However, there are complications and disadvantages, such as the significant cost per procedure, including the device, plus the filters and the tubing, the potential allergic reactions to the extracorporeal circuit, catheter-related complications such as infection and thrombosis. Others include bleeding and anticoagulant-related complications, since these patients are on a continuous infusion, air embolism, excessive volume removal resulting in hypotension, and the additional nursing training and staff required. Some nursing implications for UF. Assess the patient. Ask questions to determine their level of heart failure. Inquire about barriers to current treatments and reason for readmissions. Educate patients and families on current and cutting-edge treatments. Remember, there's more than one option. And advocate to the physicians, make recommendations, advocate, make appropriate recommendations to the care team. For more information, you can go to chfsolutions.com, which is the company responsible for the Aquadex Flex Flow, the American Heart Association, and the Heart Failure Society of America. Here's a list of our references. That concludes our presentation. We hope you've learned something. Please take our survey on SurveyMonkey.